Now this is to make a point, but I think it's important because back in the 70s in particular, there was a lot of appropriate concern about tranquilizers being handed out like candy by doctors. Get a little bit of stress, here's some Valium or something, and certainly there are many cases where that caused enormous problems. The problem with that is, well, the one side is to be very cautious about the use of these drugs with someone who's prone to substance abuse. But the other side of the coin is that the majority of people that have anxiety disorders that are treated with tranquilizers do not abuse these medicines at all. Okay? And the main way you can tell that somebody is likely abusing a tranquilizer is when they request higher doses. Because people habituate to the sedation, so you don't get quite as drowsy after a while, and they habituate to euphoria if you get a buzz off of them. But you don't habituate to the anti-anxiety properties of the drug. So in this study, see it's a very large study, this was in an HMO, and these are people that are continuously taking tranquilizers, okay, large sample size, and you can see over a period of 2 years, a little bit less than 2% requested an increase in dose. So I think pretty strongly suggests there are a lot of people that take tranquilizers and don't abuse those. Okay, now that's our algorithm. First choice drugs, okay, and about 50% of people, about 35% of depressed people have anergic depressions, and low energy. And here, the drug of choice is Wellbutrin. And the reason for this, it's just, first off, it's because it often works. But at least theoretically, it targets the two catecholamines. It increases dopamine and norepinephrine, which are energizing. Okay. Now, let me tell you something about Wellbutrin. If a drug gets a bad name, then that tends to stick. And Wellbutrin came out in, I'm guessing, maybe 1980. And when it came out, it got approved, okay, by FDA, but it had a higher rate of inducing spontaneous seizures. Now, here's the story. All antidepressants they do lower the seizure threshold. And on average, among 1,000 people, 2 people will have seizures for the first time in their life after they start treatment with an antidepressant. And there are many of us who have never had a seizure and may never have one, but we have a little bit of this abnormal electrochemical activity occurring deep in the brain that under other conditions could spark a full-blown seizure, but the seizure threshold is so high it never gets out of control. But then something lowers the seizure threshold and you have a breakthrough seizure. Okay. Now, other things that lower seizure threshold, caffeine, big time, sleep deprivation, big time. Okay, but the rate among all the antidepressants basically is 2 per 1,000. Now, this is a bit of a digression, but I'll get back to Wellbutrin in a minute. If somebody has their first seizure and they're not taking any medicine and they're over the age of 25, the number one cause for that is brain tumor. There could be any number of other things that happen. Most forms of epilepsy start in childhood and maybe very early adolescence. So there could be underlying neurologic disease. Could be also vascular, like little strokes or following head injuries, for instance. But there are people who have none of those problems. But anytime you have somebody who takes an antidepressant and they have a seizure, and in 30 years, my career, I've had 2 people, spontaneous seizures first time. They always get a neurologic exam and an MRI or CT scan to rule out brain tumor and stuff like that. In both my cases, there was no underlying neurologic disease. But getting back to Wellbutrin, it was producing 4 out of 1,000. Now, part of the original research was flawed because a group of people that were included in the study were people that have bulimia. And people that have bulimia also have much higher seizure risk because they're using laxatives or inducing vomiting, which will really whack out electrolytes in your body and can provoke seizures. But all the same, 4 is still not enough for FDA to set to, not license Wellbutrin, but it got a lot of people's attention, and rightly so. If you're a primary care doctor, you think, yeah, this person can have a seizure and have a car wreck, kill somebody, and so initially Wellbutrin was shied away from, and then about 10 years later they came out with Wellbutrin SR, sustained release. And they've actually come out with 2 other upgraded sustained release versions since then. But the SR version, instead of being associated with high peak levels that drop off, actually have a smoother curve and don't get quite as high a blood level. And if you use normal doses, and that is below 300 milligrams, the seizure rate with the sustained release in Wellbutrin is 1 out of 1,000. It's actually better. Now, the truth is, if you go way high with Wellbutrin, you can provoke seizures. When they came out with SR, Wellbutrin SR, the joke was, SR stands for seizure risk. And so lots of people, and to this day, I swear to God, I see books, psychopharmacology books, that say, be careful with Wellbutrin because of seizures. Like you get a black mark on there and it stays forever. We'll see other examples of that later today, okay? But the reason this is such a big deal is you'll be working with lots of primary care doctors, and you're going to have people that are candidates for Wellbutrin. Lowest side effect profile and very good for anergic depressions. And yet the primary care doctor might say, well, I'm a little bit worried about seizures. And then you use this phrase, yeah, me too, but I'm sure, as I'm sure you know, the sustained release actually has a lower incidence of seizures than most of the other antidepressants, as I'm sure you know. That's the phrase, right? Oh, yeah, right. Yeah, that's exactly what I was thinking, okay? Now, Wellbutrin takes a few weeks to work also. So here, what you can do is stimulant augmentation. Now, this is using Ritalin or Dexedrine or Adderall. And what's interesting about this is this has been used very effectively for 40 plus years, but there's never been any double-blind placebo-controlled study. Okay, it's just one of those things that never got any studies, but it's widely known to be useful. Okay, so this is kind of like using a benzo with an anxious person. This person can't get out of bed; they could hardly get in the car to come to your office. They go home with Wellbutrin, or it could be another antidepressant. Let's say Wellbutrin and very low dose of stimulant, like 10 milligrams of Ritalin. And what it'll do, to take first thing in the morning, and it gives them a jump start. And it really does. They feel more energy maybe than they felt in months. And the name of the game with depression in general, but especially this anergic depression, is just get people moving. You get them out of bed, get them off the couch, get them moving. And again, with these are micro doses. People can't get high on 10 milligrams of Ritalin. Right. Now, atypical depression, cardinal symptom is hypersomnia, sleeping a lot. There is not a preferred class of medication here, but this is the most important thing, and that is watch out for bipolar. But when people have depression, but they have hypersomnia, they're sleeping 10, 12, 13 hours a day, that kind of thing. And most of the time they're sleeping a lot, but they're also really exhausted despite all the sleep. About 80% of them have bipolar 2. Okay? And because antidepressants really are poison for bipolar disorder, then these are the people that often are misdiagnosed. People do not come in for treatment when they're having hypomania. People rarely come in and say, hey, I'm feeling great, I got a lot of energy, I'm real productive, everybody likes me, God's sakes, can you help me? They don't do that. And so, and in the 15-minute interview with the physician, they'll come in, with full-blown major depression, send them out the door with an SSRI, and we'll see later on why that's a mistake, but just the warning here. And the final one is premenstrual dysphoric disorder, okay? Okay, and here, the drug of choice, are SSRIs. And this has been very well documented, not only in drug studies, but also the biologic studies, that in people that this represents 5% of the population of women, that when they start having symptoms, there's this precipitous drop in serotonin levels. And we'll talk about the details of that later on. Okay, so those are the 4 categories. So that's part 1 of the initial choice of medications, okay? Part 2 is this, and that is, this is from Texas Medication Algorithm Project, but there's also a meta-analysis that came out that we'll talk about maybe later. I think I have a slide later that shows that for people who have very severe depressions, that the single agents like an SSRI are just not as good. They're just head-to-head comparisons. They're not as robust. So you go with these drugs that target 2 neurotransmitter systems. You have a higher success rate. And of course, if they have an anergic depression, you would certainly go with Wellbutrin. The rest of these drugs target norepinephrine and serotonin. Okay, so if you had an anxious depression, then you'd stay away from Wellbutrin and use one of these others. Also, if they are in their 3rd episode or beyond, 3rd, 4th, 5th, or what have you, the dual action drugs. Now, at first people thought, okay, well, are they developing a tolerance over time to the SSRIs? And probably not, because there are now many, many cases of people who it's their 3rd episode, but they never got treatment for the first 2 episodes. Okay, they do what 50% of Americans do when they get depressed. They grit their teeth, ride out at the storm, and never get treatment. So it looks like there probably are brain changes. Almost certainly, the brain can, as we talked about last time, get damaged by depression, such that if this is their 3rd time around or their 4th episode or what have you, then probably don't monkey around with SSRIs. Just go right to one of these dual action drugs. Now, this was studies done at UCLA, and what they did is they looked at standard treatment. This was outpatient mental health clinic, okay, versus targeted treatment, which used the algorithm we just talked about, using the presenting symptoms as a guideline for first choice of medication. And over 20 weeks, followed these people, and you see a 65% response rate to standard treatment and 96 to using the algorithm. Now, I want to be very, very clear about something. This is not remission, okay? Many of these people are partial responders, but still the difference is significant. So I think it really strongly suggests that, rather than just choosing some drug, out of the blue, looking at the clinical picture can make a difference. Now, the promising sort of cutting-edge research is showing that certain kinds of patterns on EEG may in fact predict which class of drugs to start with. And the latest article I read says this is probably going to be ready for prime time in a year. And wouldn't that be a blessing, to go in and have a non-invasive, EEG and find out, okay, this person, you're going to put them on an SSRI. That'd be great. All right. Now, treatment guidelines for dysthymia. No empirical studies that I've seen, although Akiskal and his group of researchers have shown good results, but this is what many people recommend. So this is consensus guidelines, not empirically derived. And of course, these 2 subtypes of dysthymia can overlap as well, but there are some people that more prominently is just irritability. These are just cranky people, they get irritated, low frustration tolerance, and then the other is like a very low grade anergic depression. I mean, they can get out of bed, but they just don't have much enthusiasm. So the recommendation drawn, from probably the other research might suggest these medications. Okay, side effects. Here is where you look at certain medical conditions that may exist that would preclude the use of some medications. Like, for instance, people who have glaucoma should never take Paxil because it can aggravate glaucoma. So we won't go into all the details of that, but that's looking at side effect of medication. Patient preferences, what they've heard, like, hey, my sister did really great on Celexa, well, good. We were thinking about SSRI anyway, let's go with Celexa, that sort of thing. And then pharmacokinetics has to do with, if you remember from last time, pharmacokinetics has to do with what the body does to the drug, okay? And this is absorption and metabolism and excretion and that kind of thing. And here also, we want to look at the potential for drug interactions, drug-drug interactions. So it's not just the clinical picture, but it's also the person's medical status, their age, and other factors that should be taken into consideration in choosing first-line medication.